So as I said, we are going to discuss something about cardiac and device infections this time. And to begin with, I'll talk about some of the definitions of infective endocarditis and what are the types of infective endocarditis. So what is, first of all, an infective endocarditis? It's an infection of the endocardial surface of the heart, which doesn't only include valves, it also includes intracardiac devices. So remember, endocarditis means infection of the endocardium, not just the valve. You have to be very clear about that. And there are multiple different types of endocarditis. Like, for example, we have left-sided infective endocarditis, right-sided, native valve, prosthetic valve, acute, subacute, and cardiac infection. Cardiac implantable electrical devices related infective endocarditis, CIED-related infective endocarditis. And if you look at left-sided infective endocarditis, it's going to involve the mitral and aortic valves predominantly. And like these vegetations are going to be really, really big, and they're going to be very mobile and friable. And that is going to pose a very, very high risk of systemic embolism. And if you look at right-sided infective endocarditis, it's very common in patients who are using intravenous drugs or intravenous drug users, or those who are having intravascular indwelling catheters, like those who are having central venous catheters for the sake of either giving antibiotics in the ICU, vasopressors in the ICU, or probably those who are using dialysis catheters. So those are at high risk of right-sided endocarditis, and they can actually cause septic pulmonary embolus, which can result in multiple cavitating lung lesions over a period of time. And they generally tend to have a relatively lower bacterial density compared to the left-sided infective endocarditis. So native valve endocarditis means you're going to involve the heart's original valves or the natural valves, and it's going to differ in epidemiology and management. We'll talk about that. Prosthetic valve endocarditis is going to involve the bioprosthetic valves, or we can call it the mechanical valves, and it's relatively more difficult to treat, partly because these valves do not have any blood supply. So it's very difficult to reach a correct concentration of antibiotics at those valves. And what about acute infective endocarditis? This is a term that's referred to a kind of a endocarditis caused by a very virulent organism, like, for example, Staph aureus. It's very common in hospitalized patients, those who are getting endocarditis because of hospitalization. And it's going to progress very rapidly over a period of a week or two. And subacute infective endocarditis is something that's going to be produced by less virulent organisms, and it's going to be more often insidious in onset, and they're going to produce only low-grade symptoms. That's why they called as SABE, subacute bacterial endocarditis, and often caused by streptococcal infections, like, for example, Viridans group Streptococcus. And we have something called CIED, that is cardiac implantable electrical device related infection. So which is going to involve the device leads, valves, or both together. And most of these infections are going to occur within a year of insertion. That's a very important point. All right, so what are the etiology, risk factors, and pathogens that are involved in infective endocarditis? So we can have a variety of gram-positive, gram-negative, and fungal organisms, and sometimes you can get a true culture-negative infective endocarditis as well. So what are the gram-positive organisms that are involved in infective endocarditis? We have Viridans group Streptococcus, Streptococcus bovis, Staph aureus, and Enterococcus. Nowadays, we are recognizing Enterococci as a predominant pathogen, especially in those patients who are having TAVI-related endocarditis. So if they ask you what is the most common organism in TAVI, that is transcatheter aortic valve implantation. So it's going to be enterococcal endocarditis. And Viridans group Streptococci is the most common cause in patients who are having community-acquired infective endocarditis. And most of the time, as I said, it's going to be subacute in nature. So for community-acquired infective endocarditis, VGS is the most common. The Viridans group Streptococcus is the most common. Streptococcus bovis can be suspected in patients who are having bowel issues. Now, the modern name for Streptococcus bovis is going to be Streptococcus gallolyticus. So if the patient is having GI issues like inflammatory bowel disease or colonic polyposis or colorectal cancer, you can get Streptococcus bovis-related endocarditis or Streptococcus gallolyticus. That's the new name for Streptococcus bovis. And Staphylococcus aureus, you're going to suspect in patients who are intravenous drug users, or probably those who are having hospital-acquired infective endocarditis. Hospital-acquired infective endocarditis. HASSEC group is very rare. HASSEC stands for Haemophilus, Actinobacter, Cardiobacterium, Eikenella, and Kingella group. So they are slow-growing organisms. Generally takes around 5 days for the organism to show up in the culture. So it's not really culture negative, but it takes a little bit of time for these organisms to show up in the culture. That's what is important point. And previously, it's been categorized under culture-negative infective endocarditis, but nowadays we don't do that. And Haemophilus can cause, Agrigobacter can cause. These are the things that are going to come under the HASSEC group of organisms. Most of them are gram-negative in nature. And when it comes to fungus, the most common fungus that causes endocarditis in the ICU patients is going to be Candida. When you isolate Candida in the blood, it's never a commensal, it's never a contaminant. It's almost always going to be pathological. If you ask me the most common cause of culture negative infective endocarditis, it's going to be Coxella and Bartonella, the two most important, but Brucella can cause, Trophema vipili can cause endocarditis, rare cause. Legionella and Mycoplasma also can cause, but these are extremely rare causes. Usually it's going to be Coxella burnetii, that is Q fever, and Bartonella species. Very rarely Brucella and Trophema vipili. Legionella and Mycoplasma are extremely rare. Coming to non-infectious endocarditis, it should not be called as non-infectious IE, rather I will say non-infectious endocarditis. That's it, that's a better term. So the most important everyone knows is Libman-Sacks endocarditis that occurs in SLE, which are sterile vegetations, and Marantic endocarditis that can occur in malignancies like adenocarcinoma, and rheumatoid arthritis sometimes can cause that. And Loeffler syndrome can cause endocarditis like picture in the form of vegetations, and acute rheumatic fever can cause mitral valvulitis. Sometimes it can mimic a endocarditis like picture. And if you look at the risk factors for infected endocarditis, so the most important I would say is prior infected endocarditis. Once the patient has got an infected endocarditis, there is going to be damage forever, and that is going to definitely increase the risk of subsequent endocarditis. And presence of prosthetic valves devices is a risk factor. Congenital heart disease of any cause is a risk factor, especially cyanotic congenital heart disease. Usage of IV drugs is a risk factor. Indwelling IV lines like central venous catheters is a risk factor. Immunosuppressed status or recent cardiac procedures also is going to increase the risk of infective endocarditis. And what are the key clinical features? The most common feature is fever that is seen in more than 85% of the patients. 85 to 90% of the patients, and most important sign is going to be a new murmur, and it's always almost going to be a regurgitant murmur, like a MR murmur, a TR murmur, or a AR murmur. And whenever the patient is having a fever and a new murmur, it is almost always in practice it's equal to IE unless proved otherwise. And patients can have weight loss, fatigue, and patients can present with embolic phenomena like stroke or pulmonary embolism, and patients can present with features of metastatic infectious lesions as well.